So hi everyone, welcome to my channel, and as per promise I have brought a very interesting revision series for you, and this is aiming the upcoming exams of NEET PG and FMG. So let us start with this series, and I have selected some important topics which have been frequently asked in your previous exams. So let us revise those topics. So I'll be conducting this series in parts. So let us start with the very first topic of the day. So students, what are you seeing in front of you? You can comment in the comment section down below, but anyways I'll discuss the answer. Yes, it's a case of neck injury, and there is a penetrating neck injury with a foreign body impaled into the neck. So now this is very common thing that that happens during the exam, that they ask you the neck of the zone of the neck injury. So let us try to start this series. So the very first thing that we are going to discuss is the concept of the zones of the neck. So when you talk about the neck injury, the very important thing is what are the zones of the neck. Now when we talk about the zones of the neck, how many zones there are? There are 3 zones. So the zones range between 2 important structures. What are they? The sternum and the sternum and the clavicle on the lower side, and then on the upper side it is the mandible. So just try to understand it grossly. So this is the mandible that we are seeing in front of us. So do you know, from the level of sternum up to the level of cricoid, the zone of the neck is known as zone 1. From the cricoid up to the angle of the mandible, the zone is known as zone 2. And above the angle of mandible, up to the base of the skull, this is what is known as zone 3. So we have zone 1, we have zone 2, and we have zone 3. They are very important. Again, one very important thing is which injury will be called as a penetrating injury, which will be called as a blunt injury. So this is important to understand, that anything which penetrates into the neck, crosses at least the superficial cervical fascia, will qualify for this. Or on the other hand, if you see the last layer of the superficial cervical fascia, what is that? I want the answer in the comment sections below. Yes, you are thinking it right. That is what is platysma. So if there is breach of the platysma at any point of time, so suppose if you see there is a weapon which has gone inside, so there is a breach of platysma. So this is what is very important. Breach of platysma is a minimum criteria to call something as a penetrating injury. So this is a criteria for penetrating injury. This is what is important. Next is one very important interesting thing is, when you talk about zone 1, this is zone 1, and when you talk about zone 3, this is zone 3. What is the basic similarity? Answer is zone 1 and zone 3 to some extent they are guarded by a bony cage. So sternum guarding zone 1 and zone 3 is guarded by the mandible. So if you want to operate on zone 1 and zone 3 and you need to expose them, you have to do a mandibular resection for 3 and sternotomy for zone 1. So it makes the surgical procedure very cumbersome. So surgery is more avoided in cases of zone 1 and zone 3 as a preliminary, you can say, management. So let us try to understand what is the management without wasting much of time. So when you talk about the management, the first thing that we all need to understand is, whenever we talk about the neck injury, the next thing is we have to see whether the patient is unstable versus stable. So unstable versus stable, this is what is very important. If the patient is unstable, the very next question that you need to ask is, which zone is actually involved. So the zone involved, you will say hardly it matters. It really matters, because if you make the incision on zone 1, directly you enter into the deep cervical fascia now, because platysma is very thin. But in order to expose zone, I'm talking about zone 2. So in order to expose zone 1 and zone 3 completely, you need to actually cut the bones, and that is where the cumbersome and time consuming affair starts. So if it is a case of zone 2 injury, the very next thing is you will go for surgical exploration. Now when you talk about zone 1 and zone 3, I apologize for my nasal tone because I am not well today. I am having a very severe cold, but as I have promised to my students that I will be coming up with a video, so I decided to come up with the video because your time is more important than me and your blessings will always let me heal quickly. So try to understand if it is zone 1 and 3, why not try to first embolize and control the bleeding vessel. So this is where you go for angioembolization. So angioembolization happens. Now this is very much beneficial. Why? Because in certain cases it will stop the bleeding. If it is not, then at least it will retard the flow of blood loss, and that is what is giving you a time frame. So if it fails, definitely you will have to go for surgical exploration. This is what is very, very, very important. So you know, zone 1, zone 3 management is same. Now if it is a case of penetrating injury, I have told, if it's a patient, if the patient is stable in contrast to unstable patients, how do we manage? So there could be a possibility that there is no injury. So why not just confirm it with a scan? And that is why you are going to go for CT scan. Now when you go for CT, the first question is CT sufficient to visualize a blood vessel? No, you have to add an IV contrast and visualize the vessels also. So CT angiography is what we are going to do now. Now you must be thinking, sir, here you are not prioritizing any zone. So answer is, for stable patients, we use a no zone approach. Students, this is a very famous question, that no zone approach is used for. Answer is stable neck injury patients. So on CT angiography, you will ask yourself about the injury, whether or no there is injury. If there is injury, yes, then the first thing that you will go for maybe a CT guided or USG guided angioembolization. If it is no, then what is the next call? If it is no, that is there is no injury, then observation is the call. So this is how you are going to manage the things. So we have got the answer to our first question. So identify the zone of the neck. Answer is, it is zone 2 of the neck. And what is urgent surgical exploration? We need to go forward. The second is a very common question nowadays. It has been asked in INI-CT this year also. Last year it was asked in FMGE also. So what are you seeing classically in front of you? Yes, you can quickly answer in the comment section. Now try to understand that the things that we are seeing is, we are seeing a dilated bowel loop. So we are seeing a dilated bowel loop. Yes, dilated bowel loop. Now the next thing that you can appreciate here is a coffee bean appearance. So you have a coffee bean appearance, classical coffee bean appearance, and that is sufficient to confirm that this is a case of what? Sigmoid volvulus. Try to understand, when we talk about sigmoid volvulus, you get to see a lot of things. You get to see a coffee bean sign, you get to see a bent inner tube sign. Why a bent inner tube sign? You can see that if you take a tube and you bend it, the inner side will become more curved. So bent inner tube sign also, inner tube sign. But I am not interested in all these things. Now there could be early signs, or there could be early phase of this volvulus, and it becomes very difficult. So my always objective is to look at the apex. So I always concentrate on the apex of this volvulus. If the apex is towards the right upper quadrant, it is a sigmoid volvulus. So we surgeons have a different way of approaching it. Usually the apex of cecal volvulus is in the left upper quadrant. Now there is an exception to this rule also. What is that exception? Try to understand. A huge volvulus, a huge sigmoid volvulus will have a transition from right to epigastric, even to the left side also. So the answer we have is sigmoid volvulus, but we will revise some important points, the differences between the cecal and the sigmoid volvulus, and all the important things that we can understand quickly in a nutshell. So I hope you know what is a volvulus. Volvulus is nothing but it is a twisting of bowel on the axis of its mesentery. So this is a bowel which has twisted on its you can say mesentery, and since it has twisted off, there are two problems which have been created. What are the problems which have been created? Now try to understand, this end is also blocked, this end is also blocked, and thus it results in a closed loop obstruction. So this is a closed loop obstruction of a bowel. So what is a volvulus? It is a closed loop obstruction of a bowel by twisting of, you can say, a bowel on the axis of its mesentery. This is what is very, 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 very important. Now, I'm not going to start this chapter of volvulus. I'm just quickly going to discuss few important things. How to differentiate. So how to differentiate, and that is on radiology. So how to differentiate between a cecal volvulus and a sigmoid volvulus. So cecal volvulus will have a different presentation, sigmoid volvulus will have a different presentation. No, it is not so. Clinically, they both have the same presentation of intestinal obstruction, but on radiology, there are a hell lot of different. So if you talk about the clinical presentation, the clinical presentations are the features of intestinal obstruction. So the features of intestinal obstructions are always there, and you know, vomiting, distension, pain in abdomen, bloating, constipation, they are classical things. So we have cecal volvulus, and we have a sigmoid volvulus, cecal volvulus and sigmoid volvulus. Now let us try to understand them. On radiology, so on X-ray, how to see them? On X-ray, look at the apex. So if I talk about the apex of cecal volvulus, this is how the cecal volvulus is. So this is how the cecal volvulus is. So you can see the tip of the cecal volvulus, the apex, I would say, the apex of the cecal volvulus is towards the left upper quadrant. Point number one. This is what is simple, very, very, very simple. Then try to understand, since it's a volvulus, there will be some air fluid level also. So you can say that there will be a single air fluid level. Single air is to fluid level, and they are very important things, single air fluid level. The third very important thing is the classical shape that you have. So a teardrop shape, we have a teardrop shape, or you can say a comma shape. So a teardrop or a comma shape we have. This is what is important. So teardrop and comma, and this is important. Now next is, let us talk about the sigmoid volvulus. So it's a beautiful thing to see. So this is the sigmoid colon which is coming down, and it's a huge structure which is giving you the typical feel of a what? A tire like, you can say. Whenever you see a classical case of sigmoid volvulus, it will give you the classical tire like presentation. So now what about the apex? So if you see the apex is towards the left upper quadrant or right upper quadrant, it is towards the right. I have already told you that apex is towards the right upper quadrant. What else? Now here in cecal volvulus, you saw a single air fluid level. Yeah, this is what you saw. Here, let us try to understand, figure out a lot of things. So this is, let us take this to be the volvulus segment, and I will draw it for you. I love drawing this volvulus always. So this is the air fluid level in this column, there is air fluid level in this column. So can't you see that there are two fluid to one air column? Instead of single air fluid column, two fluid to one air column, point number one. The next thing that you need to appreciate is, this is one air fluid level and this is another air fluid level, and this is what is known as pair of scale sign. So we have something which is known as pair of scale sign. The next thing that we all get to see is a classical coffee bean appearance. So you have a coffee bean appearance. What else do you get to see, students? So we have a coffee bean appearance. Come on. Yes, you can answer in the comment section. I've already discussed. You get to see a typical omega sign. Then you get to see a bent inner tube sign. Bent inner tube sign. What else will you get? Try to understand. This is very artistic. So if you see, this is one border of the bowel that is visible. Then there is one more border of the bowel. Let me take it with a different color. So this is one more bowel line. And then you get to see one more line. So if you see, there are three lines intersecting at one point. This is not possible until unless there is a twist. Otherwise, you will always see two parallel lines. So remember, three lines intersecting. So what is that? There are three lines intersecting towards pelvis. And what is this sign known as? First of all, this is confirmatory that it's a twist. And then this is known as Freiman-Dhalman sign. Freiman-Dahl sign. Freiman Dahl sign. So these are some important things that you need to understand. Remember, what is the management? Let us quickly talk about the management of volvulus. So when you talk about the treatment of volvulus, you know that volvulus is a surgical emergency, everyone has to understand. So treatment of a cecal volvulus first, that let us talk about. You know what is the worst thing about cecum? Cecum is the thinnest organ, and if you dilate it during obstruction, it is going to be more thinned out, and that is why perforations become very common. So cecal volvulus, the next thing that you need to understand is you have to go for surgery. So exploratory laparotomy. Now, do you know that it is intestinal obstructions, acute intestinal obstruction, where you don't go for laparoscopy because abdomen is distended, creating a pneumoperitoneum vision becomes a big task. So exploratory laparotomy, and then you ask yourself about the cecum. So check viability of cecum, and this is what is very important, whether the cecum is okay, whether the cecum is healthy or no. So the next is cecum is viable. So if it is viable versus the cecum is gangrenous. So if it is gangrenous or necrotizing, the next thing that you need to understand is you have to go for resection plus anastomosis. We prefer to go for right hemicolectomy. In most of the cases, you can go for right hemicolectomy, and along with that, with iliotransverse anastomosis. Why it is preferred? Because you could also have gone for an ascending colon and you can say ileal anastomosis. Let me tell you, it's not wrong, you can do, but majority of the time in cecal volvulus, some part of the ascending colon is also sacrificed. So we prefer to go for right hemicolectomy. It's depending upon the surgeon to surgeon what they want to do. So if you do ascending colon only resection of the cecum, and you do an ascending colon to you can say ascending colic and ileal anastomosis, that is also not a wrong thing. So if the cecum is viable or healthy, you have two options. One option is resection and anastomosis. This is one option. Another option is cecal derotation, and along with that cecopexy. If you ask me, sir, what is the option which is preferred, I would always say that it is the resection and anastomosis which is always preferred in these patients, because the risk of recurrence is minimized. One very important thing that you all need to understand, important is there is no role of endoscopic derotation. This is what is very important. Endoscopic intervention is not at all recommended in any case. The next is, let us talk about the management of sigmoid volvulus. This is again very important. So when we talk about the management of sigmoid volvulus, what are the things that you need to understand? Sigmoid volvulus. Students, the first thing that you have to ask is whether the patient is stable or whether the patient is unstable. Now, why there's a question of being stable or unstable? Try to understand. There are many patients who have chronic volvuluses. So they are habitual recurrent volvulus patients. So there, try endoscopic derotation first. So if the patient is a chronic patient with stable status, hemodynamically the patient is stable, try endoscopic derotation. Now when we talk about endoscopic derotation, how it is done? This is done via flatus tube or simply a colonoscope. Now what do you mean by a flatus tube or a colonoscope? It is very simple. If you blow a balloon, try to see this volvulus like this. So usually these are the patients where you will push you can say a tube inside, and the moment the tube enters into the volvulus segment, all the air will come out with a hiss and this will derotate and collapse. So suppose if this fails, then you will have to go for surgery. And what is the surgery that we go for? We go for resection plus anastomosis. resection plus anastomosis. This is what is very, very, very important. And when you're talking about resection plus anastomosis, what we go for? We go for a distal sigmoidectomy, with ileocolic with colorectal anastomosis. Colorectal anastomosis. So this is what is done. So with the descending colon, you anastomose the rectum. Next, very important thing that we need to understand is, what is the concept of unstable managed patients? Now, colon is a very precarious organ. The blood supply is very much jeopardized, and thus the risk of perforation peritonitis is very high. So, unstable patient, you don't waste your time in all these idiotic activities. Simply go for the treatment, and the treatment is your surgery. And what is the surgery that we go for? We go for resection, and along with the resection, we plan diversion colostomy. Now, resection of the volvulus, and along with that, we will plan a diversion colostomy. Now, when you talk about diversion colostomy, what are the important things that you need to understand? Let us try to see all these things, diversion colostomy and everything. So, let us simply take this image as an example. So, this is the sigmoid volvulus that we have. Okay, this is the sigmoid volvulus that we have. So, the first task, as I have already told you, is the resection. So, we are going to do the resection. So, let me do some resection for you. So, this is the resection which has been done. So, the portion is out. Now, what is the next thing that you need to understand? The next thing is that how to manage the two ends. One is the end of the descending colon and one is the end of the rectum. So, either there are two options. Either you can go for anastomosis. I have already told you about this concept of anastomosis, that is the resection and anastomosis. But resection and anastomosis is done for stable patients. For unstable patients, what is the aim? If you attempt anastomosis here, due to intense inflammatory cascade which is running in your body, there will be a leak. And if there is a leak, there will be fecal peritonitis, and then you will not be able to save the patient. You lose all the chance. So, in that case, the plan is diversion colostomy. Now, what is the concept of diversion colostomy? What is? So, colostomy is of two types. It is permanent when you completely excise the rectum and anus, or it is diversion temporarily to divert the stool. So, suppose this is the colon, and what is the physiological importance of the colon? That it is a pathway via which the fecal matter transits into the rectum and anus. So, I will mature a stoma over this. So, the fecal matter will come out by this. So, if I let us take a walk inside the colon, I am going, moving, and all of a sudden I am out of the colon. And that is why this type is known as end colostomy. So, I have ended the colon into a stoma, and that is why it is known as end colostomy. The next thing that we need to understand is how to manage the neck stump. This is the rectum, this is the rectal stump. So, there are two possibilities. Either you mature a stoma out of this also. So, end colostomy with a mucus fistula. Why it is known as a mucus fistula? Try to understand. Because since this is a colon is lined by columnar epithelium, the mucus shall come out from this, and mucus shall come out from this also. So, opening on two sides is a fistula, and that is why end colostomy with a mucus fistula. Or the second option is, what is the second option? I can do a closure of this stump. So, end colostomy with the Hartmann's pouch. What is the concept of this Hartmann's pouch? Let us try to understand this. End colostomy with a Hartmann's pouch. So, this is the colon that I have, and I have matured into a stoma. So, this is end colostomy. Now, if you see in this case, the lower end is not big enough, so I cannot stretch it and get it up. So, what I will do, I will close it with a Prolene suture. And after few weeks, I will do an anastomosis with the stump. So, this is done in this case also. After few weeks, we will anastomose it and establish the continuity. That is why it is a temporary diversion. So, if you do the closure of the stump, if you do the closure of the distal stump, this is what is known as, so end colostomy. This is basically end colostomy with closure of the distal stump, and that is what is known as a Hartmann's procedure. And this is what is very, very, very important. So I hope you must have got some idea in this revision, because colon is a very important, and I have been seeing a lot of topics from this. So let us try to understand this question also. You have a thyroid scan in front of you. So if you read the history, long standing thyroid nodule with sudden onset of toxicity, and patient underwent a thyroid scan, and this is what you are getting on the thyroid scan. So what is it? Let us try to understand the basic concepts of this. So approach to solitary thyroid nodule, basically we are going to study here, and let us see. Whenever you have a solitary thyroid nodule, what is the problem of solitary thyroid nodule? Now, whenever you have a patient of solitary thyroid nodule, the first concern that we have clinically is, there is a nodule in the thyroid, could it be a cancer? But obvious, everyone is scared. Could it be a cancer? Doctor, tell me. Or even when a patient comes to us, sir, tell me what to do with this. So you are always thinking that if it is a cancer, the management will be in a different ground. So approach to solitary thyroid nodule. Now, the first thing that you need to understand is assess. So clinical assessment is very, 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 very important. Clinical assessment is very important. And in clinical assessment, there are a lot of things. What are the features? What are the features suggestive? What are the features suggestive of malignancy? So what are the features suggestive of malignancy? You need to see them and rule out. So what are they? Age. Do you know that thyroid nodules seldom occur in kids, but if they occur, they are seldom benign. So age less than 15 or age more than 40 years, they are all indicative of malignancy. Next is gender. When you talk about gender, thyroid swellings seldom occur in males, but if they occur, they are seldom what, students? Benign. The next is the thyroid size, the thyroid nodule size. The rule of thumb is nodules more than 4 centimeter in thyroid, they are seldom what, students? Benign. Next is history of radiation. So history of radiation, this is what is again very, very, very important. So doctors who are working in OT, they are exposed to X-rays, anesthetists, urologists, gastroenterologists. So there are a lot of people, orthopedicians, are routinely exposed. Or if you have undergone any treatment for, you can say, facial hair removals, you are. Or if you are born in a war zone where actually there would have been a mishap of nuclear things. So these are some important things that you need to understand: age, gender, size. Then family history. Then you have a family history. And what else is important? What else? Answer is the thyroid functional status. So how do you see the thyroid functional status? Right now you have seen one very important thing, that is a thyroid scan. So do you know that there is a dictum that empty mind is devil's workshop? Yeah, this is true. Try to understand a cold nodule. The cold nodule has an increased risk of malignancy, and how much increase? Answer is 15 to 20% of them, and this figure is again important. If you talk about hot nodules, it is less than 5% of them are associated with increased risk of malignancy. So now, how to evaluate? We get one more question, that what is the investigation of choice for any solitary thyroid nodule? And this was a question this year also in INICET. It is always USG guided, but the investigation is what? FNAC. So investigation of choice is FNAC, it is USG guided. Why it is USG guided? Because you do a simultaneous assessment of the nodule radiologically also with precision of the point from where you want to pick up the tissue. So if you have a tissue and that is you can say when you talk about the nodule, many of the nodule have a necrotic content also, since this is a complex small area. So there may be compression necrosis also, and suppose if you pick up necrotic content in FNA and say this is inflammatory necrotic nodule or colloid nodule degenerative type, and you start the patient on follow up, and by the time in 6 months the patient goes into a state of metastasis, patient will sue you. So try to understand USG guided FNAC has two advantages. It decreases the false negative reporting, point number 1. The second is simultaneous assessment. So there is simultaneous assessment. Now what are the radiological features or USG suspicious features on USG? Now this is again very important questions. So suspicious features on USG. The first very important thing that you have to understand is the orientation. Now gland is tall or wide, it is wide. So anything in the gland which is taller than wide, so taller than wide, this is what is very important thing. So this is suspicious, point number 1. The second thing is presence of microcalcification. Now what do you mean by microcalcification, students? Less than 5 mm multiple discrete miscellaneous calcific deposits. The third is presence of internal vascularity. So if there is internal vascularity, what else is important, students? Irregular borders and heterogeneous ecostructure. So irregular borders, then solid or cystic, it is the solid, and then it is heterogeneous hypoechoic. So heterogeneous and hypoechoic. So they are all the important things that you need to be aware of the aware on the USG, because these are suggestive of malignancy. Now let us have an algorithm of approach to solitary thyroid nodule. So whenever you have a patient of STN, solitary thyroid nodule, the first concern that you have is that okay, this patient is having a nodule in the thyroid. Is it associated with hyperthyroidic profile of the patient or hypo or euthyroidic profile? So the next thing that you check is the TSH levels of the patient. There could be two possibilities in the TSH levels. What are the two possibilities in the TSH? That it could be low TSH or it could be high TSH. High TSH means it is hypothyroidic. So in hypothyroidic patients, colloid nodules are very common, or the goitrous colloid nodules are very commonly seen, or it could be euthyroidic patients. So euthyroidic, that is a normal patient, a normal TSH. Now try to understand, if it is a patient with low TSH, that means that this is hyperthyroidism. Now you need to confirm whether the gland is working more or whether this nodule, and for that you go for a what scan, students? Thyroid scan. You can use technetium, you can use iodine 123. So on technetium scan or thyroid scan, if you get a hot spot, so that means this is a functionally active hot nodule, and this is a case of toxic adenoma, and that is the place. So toxic adenoma, if it is the diagnosis, the management of that toxic adenoma is surgery, and you go for hemithyroidectomy. Now the problem is not in this. The problem is that if the thyroid scan is normal, or you can say if it is cold, now this is where the problem arises. That complete gland is working and this nodule is not working. So it needs a future and further evaluation, and how you will take it to the same group where hyperthyroidism is not there, hypo or euthyroidic status is there. So that is the place where will you go for USG, ultrasound, USG of the neck. So USG neck is what is we will go for. Meanwhile, you will treat hyperthyroidism. You will treat hyperthyroidism with anti-thyroid drugs here. So it is move forward. Now you go for USG neck. Now how to evaluate this USG neck now? In this you will check whether it is cystic or whether it is solid. Both of them are very important. Whether it is a cystic swelling or whether it is a solid swelling. Students, if it is a cystic swelling, then you will go for aspiration, and not only aspiration plus assessment. So you will not throw the aspirate, you will go for aspiration and you will go for assessment. On aspiration assessment, if you see that it is a malignant cyst, you will have to go for surgery. If you see that it is a benign cyst on aspirate, then that is what is observation. Now, these are very important things. If you talk about a solid cyst, what is the next thing that you need to understand? Again, the next thing that you will need to understand is the size. If the size is less than 1 centimeter, you are going to go for observation. And how do you observe this? This is again very important, with 6 to 12 monthly USG neck, and this is what is very simple. If it is more than 1 centimeter, now here the problem arises. Why? Because you want to know what is inside, and here you go for FNAC. Now, if you are going for FNAC, the next thing that you are going to ask is whether it is malignant, whether it is query malignant, whether it is Hurthal cell type. So, whether it is Hurthal cell, whether it is malignant, whether it is atypia of unknown significance, this is AUS, or nowadays we also have FLUS, follicular lesions of unknown significance. In any of them, you are going to go for surgery, and this is decided, surgery is to be done. Now, if it is found to be benign on FNAC, what is the next thing that you will go for? You will go for follow-up or observation with 6 to 12 monthly USG. This is what is very important. So, in a nutshell, you know that whenever you have a solitary thyroid nodule, check the thyroid status, hyperthyroidic, evaluate it with the thyroid scan. If it is a hot nodule, yes, toxic adenoma. If it is a cold, yes, then you will have to further evaluate it like a nodule in a euthyroidic or hypothyroidic patient, and this is how you do. If it is a cystic, aspirate, NC, malignant, surgery, observation if benign. If it is a solid, size is very important, less than 1, observe, more than 1, FNA. So, it's not like that we do FNA for every patient. So, we have to see all these things. So, next, let us go to the next question and see what the question is. Now, let us see this next question. It's a very important question. Identify the knot shown. So, you can see a knot in front of you, and it's a very important question for you also. Identify the knot. So, whenever you get a tooth row knot, it becomes very difficult for any student to understand what is the concept of tooth row knot. So, whether it's a reef knot or an Aberdeen knot, let us try to understand everything. So, when you talk about the knots, it is very simple to understand what are knots. Knots we have of two types. Either you have the open surgical knots, or you have the laparoscopic knots. So, we have laparoscopic knots or open surgical knots. Let us try to understand the difference between the two, but before that, let us see the open surgical knots. Open surgical knots, what are they? They are either a tooth row knot, When we talk about tooth row knot, what are the concepts of tooth row knots? They are of two types. Either it's a reef, so it's a symmetrical tooth row, and we have the granny's knot. What is the granny's knot? It's a classical, when you talk about grannies, it's a asymmetrical knot. So, when it is asymmetrical, you need to understand that it is often unsecured. So, which one is a secured knot? This is reef, which is a secured knot, and this is unsecured, and therefore, you need an extra hitch on it, and therefore, it is also known as a slip knot. So, you must be thinking that someone who is creating a granny's knot is a fool or a moron, he is not knowing how to create the knot, but this is wrong. Why? Because granny's knot is of paramount importance. If you don't know granny's knot, then you don't know anything. The difference between is the application. So, when do you use a reef knot? When the point of creation of the knot and tying of the knot is same. That is the place where you need a reef knot, because it gets locked. But when you have a point of creation of knot and tightening of knot as a different, you can say there's a difference in this origin versus the execution of knot. There you have to use a grannies. Like suppose if I'm doing a laparotomy, so my organ is inside. Suppose I want to tie the uterine vessels down there in the pelvis. I will slide the thread up to the uterine vessels and then I will secure it. So if I have a reef knot, it will get locked and it will not go to that point. So this is very important, that if the point of execution and the origin is same, we use a reef, else we use a granny's knot. You can see my other videos, there is a detailed concept of them, knots in them. Then we have a 3-throw square knot. We have a 3-throw square knot, or you can say 3-throw knot. When you talk about 3-throw symmetrical knot, what is that knot known as? That's a surgeon's knot. Now what is the difference between a surgeon's knot and a reef knot? In reef knot, there are two symmetrical throws. What is the concept of two symmetrical throws? I will define it to you. The third is Aberdeen's knot. Aberdeen's knot. When we talk about Aberdeen's knot, it is loop out of loop knotting. So loop out of loop knotting, this is what is very, very, very important. The next is, when we talk about the laparoscopic knots, what are the knots that we have? We have the surgeon's knot, we have the surgeon's knot, this is point 1, and the second that we have is extracorporeal slip knots. Extracorporeal slip knots. Now what do you mean by extracorporeal slip knots? They are created outside the abdomen, but they are secured inside. The classical knots that we have here is a Rodder's knot. Now when you talk about a Rodder's knot, you must have seen a lot of my videos where I teach this 1-to-1. 1-to-1 is Rodder's knot. The second is a Melzer's knot. Melzer's knot. So when you talk about a Melzer's knot, it's a 2-3-2. Then I have my own knot configuration, which I with proud teach to my students who come for laparoscopic training to my institute. That's a SD's knot. So I talk about the SD's knot. It is nothing but a modified Melzer's knot. SD means my brand. It's SD, you must have seen everywhere. So it's a 2-2-2. We will be seeing them, but before that, let us try to understand how to identify a knot. So whenever you have a 2-throw knot, how to identify a knot? Select any one side. Select any one side, and then look for the symmetry. Look for symmetry. If you have a symmetrical knot, if it is symmetrical, then that's a what? A reef knot. That's a reef knot. And if it is asymmetrical, then that's a Granny's knot. So try to understand a lot of things here. Let us see. If you see this end, the orange thread, the orange is below. So if you see here, the orange is below the blue thread that you are seeing. If you see this thread, again the orange is below. So orange is below in this case. Similarly, if you see this thread, the blue is above. Here also the blue is above. So this is a symmetrical knot, and that is why this is what is considered as a reef knot. This is what is very, 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 very important. So dear students, I will show you how the concept of knotting is. So this is one thread. Now how to create a symmetrical knot. So this is one end, this is one end. So if right end or left end, so if the right end is going from top, so can you see the right end is coming on the top. So if the right is coming from top, it will always stay on top. So just see, I am taking it and crossing it. To tie a knot, you have to always cross it. Again, I will put the right on the top and then again cross it. So can you see the classical configuration of the knot that is created? The knot that is created. This is what is a what knot? This is a reef knot that is created. Now if I tighten it, it will get locked. It will not glide it. So this is reef knot, you maintain the symmetry. Now I'll create a Granny's knot for you also, try to understand. So this time I will not maintain the symmetry. Right is coming from top, and here the right is coming from below. So I've created a knot, and can you see I am sliding it, I am gliding it, I am gliding it, I am gliding it. So this kind of knot is a what? Slip knot. And in order to secure it, we'll first glide it to the point where we want it, and then we will tie it off. Now when you talk about surgeon's knot, it is again the same. Instead of this, you have initial 2 throws and then 1 throw. So this is symmetry, right coming on the left and then again right staying on the top. You can follow the symmetry. If you want left on the top, you can follow. So this is a reef. Can you see this is a reef? Now if I do the same concept, but initially instead of 1 cross, I will do a 2 cross. Just see, first, again second. So I have made 2 crosses here. And then again I do a symmetrical crossing. So this kind of knot configuration, this is a what? This is a surgeon's knot and Granny's knot. So something on laparoscopic knotting we'll see in another video, and this is what is the part 1 of this video. We'll be coming with part 2 also. So do subscribe to my channel, do share it, do like it, do comment in the comment section what else you like, what else you want to be recorded for you.